2+ would be marked edema of the lower extremities. 3+ is marked edema involving the face, the hands, the lower abdominal wall, and the sacrum. And then 4+ would be generalized massive edema with ascites. You can see it's becoming more and more complex. One thing I want to point out, compared to what we talked about in the first week, remember our edema, we expected normal edema because of gravity, the decreased perfusion, the relaxed vessels, the big old baby in uterus sitting there blocking the flow. When you get edema above the waist and above the heart, that is not gravity. That is some kind of kidney that's more than likely not able to take care of all the load. So this is where we go. 1+, 2+, it's the lower extremities. It may or may not be a disease process. You start moving into your 3+, 4+, it definitely is a disease process. So keep that in mind. It's where you see the edema and the degree to which you see the edema. 2+, yeah, it's still in the lower extremities, but it's pretty severe. So you got to keep these kind of different categories clear.
Disease is 2 to 4. The one is.
I would think disease was 2 to 4. I think that's safe to say. So our definition for gestational hypertension. Now remember me and my words, gestational, having to do with gestating, having to do with a pregnancy and having a child. So if you're on an NCLEX and you just freeze with the moment gestational hypertension. Remember, gestational having to do with having a baby, hypertension, blood pressure higher than normal. We're characterized by a blood pressure of 140/90 on or more, at least 6 hours apart. Here we go again with the 6 hours apart thing. Occurs during pregnancy, unaccompanied by any other signs and symptoms of preeclampsia, and it resolves within 12 weeks of delivery, which means it's a blood pressure that appears during gestation, and then it's gone when gestation's completed. It just goes up for some reason, and we don't know why. Because she's not having any symptoms of the advancing disease of preeclampsia. She just has the blood pressure up while she's pregnant, and then it goes back to normal after she delivers. That's the overall definition of gestational hypertension. Now we're getting a little more specific, we're getting a little bit more serious. Preeclampsia. Pre meaning before, eclampsia meaning seizure, convulsion. So this is a process, it's a disease period before she has the convulsion. And hopefully we're going to keep her from having that convulsion by our intervention. So preeclampsia involves hypertension occurring in the second half of pregnancy, and you need these to have the definition or to have the diagnosis. In the second half of pregnancy, and you have proteinuria with it. So you need those 3 criteria to classify someone as a preeclampsia. It needs to be hypertension, it needs to begin the initial diagnosis is in the second half of pregnancy, and you need to have proteinuria with it. So then if we, and preeclampsia is either mild or severe just based on the values that you're getting. And then if she does progress and have a seizure, she has eclampsia, and that's with preeclampsia advancing to maternal seizures, which is very, very serious. You have this chart here, and don't freak out about it. It's really just to kind of show you physiologically what's happening to our mom. This is a disease of vasoconstriction and interior wall damage in the vascular system. So we've got to see why she's having, we don't know why. We know it's something to do with the placenta, but we don't know why. So I have my visual aid here. Got these at Home Depot. So let's talk vasoconstriction. We've got a nice, healthy, relaxed blood vessel here. Remember, we've got progesterone, so it's basically relaxed. This eventually, in a pregnant woman, because of these kind of hormones, we have an increase in the vasoconstrictor hormone and a decrease in the vasodilator. That's all you need to know about that. Okay? So what happens when we have vasoconstriction? Well, our vessel goes from a nice, fat, juicy one to a much more constricted one. So we're still trying to put the same amount of blood through this, and what's going to happen to our walls? They're going to be pushed out because you're still trying to squeeze the same amount of blood through this, but you're putting pressure on the wall. So there's the increased blood pressure. Okay? These are permeable, remember? So what happens when you have all that blood pushing on these permeable walls? It pushes out into the tissues. So there's our edema. Edema is very, very classic for this diagnosis. Well, as a result of all that pressure on these walls, there are damaged areas. This is my damage. So I got this pressure in this one site, pushing, 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 and eventually the pressure, now I've got it not going in, but if it was coming out, would damage different sites in the vascular system. With me? So we have endothelial, that inner lining, damage throughout the whole system. Now, after time, it gets even more constricted, and we're dealing with something like this. So again, same amount of blood trying to squeeze through this tiny, tiny vessel. The pressure on it is amazing and very high. The edema and the diffusion of the fluid out is high, and all along it is damaged vessels. So here's our vasoconstriction, here's our fluid shift, and then as a result of those damaged areas, what happens when we cut ourselves? We bleed, and then what happens? We don't bleed, we clot. And how do we clot? Platelets, fibrinogen, all those clotting factors come to our wound and start doing their magic. Well, they do the same thing here, but they're not really needed here, but they think they are. So you've got all those clotting factors and all those platelets running to all these damaged areas along our vessel. So you got a lump of platelets here, you got a lump of platelets here, you got a lump of platelets here, and it's blocking the flow even worse. Because it's kind of like an obstacle course now. The blood's going through a smaller vessel anyway, but now it's bumping into all those globs of platelets. So it's even reducing the amount of circulating blood because it's got these globs of platelets. And here is our third factor, the intervascular coagulation. So these are the three things that are involved in the gestational hypertension leading to preeclampsia. We have our increased blood pressure, we have our fluid shifts, and we have our intervascular coagulation. Everybody with me so far?
Yeah, I hate that part. I missed the beginning part. What was the
I didn't talk
catalyst
about
for all
that.
this?
We don't know.
Oh.
The only thing we know is when we take that baby and the placenta out of her, she gets better. So, the research is pointing to something in her placenta that in some women caused this reaction. Some secretion, some chemical, some protein, something that in her placenta causes this to happen. Jennifer?
Could it, I mean, given that it's more prevalent in really young or older women, could it be hormone related?
Could it be?
They have different hormones.
Could it be? Yeah.
Could it, what about genetics? I mean,
There is
they
genetics.
just discovered the MTHR gene that causes coagulation problems?
There is a genetic component. When we go through the risk factors, there is a familial connection to this.
And that's not diagnosed. A lot of
Right.
people.
So there must be something that is kind of running through families that predisposes you to this. But we still don't, we haven't been able to isolate what it is. Does anybody watch Downton Abbey?
Yeah.
Did you see the preeclampsia one? I was trying to find a way to bring this in. Anybody know how I can do that?
On the internet.
Netflix?
Actually, it's on, yes, you can, it's on Netflix.
It's everybody familiar with what Downton Abbey is.
First season.
Early 1900s, rich family in England, their daughter is pregnant. And she starts to complain of very subtle symptoms, and their snooty doctor says, oh, it's normal, normal, normal. And the country doctor from the community says, no, I think this is a problem, I think it's a problem. Well, she ends up dying in front of them. And the snooty doctor is just totally blown away that he missed the diagnosis, but it's very classic that she just starts to have a headache. It was great, so I'll work on that. So, we got the hypertension, the edema, and now we got the coag problem. So, why I'm making you look at this ugly sheet is to show you what you're gonna be seeing in your patients and how to pick it up as early as possible. This is a disease that can go from bad to worse very quickly, or it can be a very subtle. You know, we see her that last month, we're seeing her every week in the prenatal clinic. Her pressure's up a little bit, she's got trace protein, and next week her pressure's up a little more, she's got a 1+ protein, and she's kind of puffy. So it's something that if we know what to watch for, why it's happening, it helps us get it as soon as possible. So first thing, we got our vasoconstriction, so we got our hypertension. Now, all of these problems in the vessels are happening in the big vessels, and they're happening in their microscopic teeny tiny arterioles. So here we got those uteroplacental arterioles, same thing's happening. So if we're blocking the flow of the blood to the placenta, what are we gonna see? We're gonna see a growth restriction in our baby, because the baby's not being perfused. We might see a problem with the placenta where it abrupts and just detaches from the uterine wall. And you're gonna talk about that with Dr. Piper today. And then you can see the uterus just get a little bit more irritable. When there's no perfusion to a muscle, it gets a little bit more irritable. Glomerular damage, again, same thing happening in the kidneys. So we're gonna see her spilling proteinuria. We're gonna see her plasmic uric acid and creatinine and BUN and all those kidney values increase. We're gonna see a decrease in urine output. Because no blood's coming to the kidneys, so we're not gonna see as much urine. And we're gonna see her start to increase sodium retention along with the edema. Here's our edema. So it's gonna be, again, we're into that +3 area. We see it above the heart, so it is not gravity doing this to us. And it's hitting in her lower extremities, even after 12 hours of bed rest. Now, when we go back to our gravity-induced edema, you know, think of the nurse that works 12 hours, or just the pregnant woman that's on her feet 12 hours, or patients you had with heart disease. When you put them to bed, and there's no gravity, and they're horizontal, more than likely, we expect the edema to resolve somewhat. So that when they get up in the morning, they're not as puffy in their legs as they were when you put them to bed. Doesn't happen with these folks, because it's not gravity, it's their kidneys and the edema. So you can put her to bed for 12 hours, and she's still gonna be edematous when you come back and see her 12 hours later. Cortical brain spasms, I need vessels in the head. They're getting blocked by all the coags, there's increased pressure, and we're inclined then to have her complain about headaches, hyperreflexia, which is why we check the reflexes on our postpartum moms, because sometimes that's the first thing you find on them. Whoa, your reflexes are brisk today. And then seizure activity. Pulmonary edema, we all know it's gonna cause dyspnea. Same thing in her eyes, the retinal arterial spasms. So her vision could be affected, could be blurry, she could have spots before her eyes, which is stotoma. Hemolysis of red blood cells, and this is important. Remember when you learned about either giving blood or drawing blood? What did you learn about the needles you would pick to use? Or what? Want to hurt them all? You just want to hurt those patients? Why are you doing that to them, Abe? Why? Exactly. They're fragile little donuts. If you squeeze them through tiny spaces, they break into pieces. So, we're supposed to be putting our nice little blood cells through this, but now we're forcing them through here. We're breaking our blood cells just by having them perfused through the system. They're also bumping into all those coag blobs all through it. So we're gonna see a lot more hemolysis in these women, which right here is gonna be a decrease in her hemoglobin, and we're gonna see her bilirubin go up as those blood cells break down. Then her liver gets involved too, again, the microembolite are there, so we're gonna see her liver enzymes go up. Nausea and vomiting can be a problem. Epigastric pain and or right upper quadrant pain. Remember, everything is up here. We pushed everything, so we don't know exactly where anything is anymore. So any pain up here could be a problem. Her blood glucose can go down, and our ultimate disaster with this disease process is her liver will rupture. Now here's these platelets down here again. They're aggregating and they're just depositing all over the place. So when we go to draw her blood, we're going to see a decrease in the specimen because all her platelets are in globs. They're not circulating around to do her any good. So another process in this thing is watching her platelets go down. As her platelets go down, we know she is having those fibrin deposits. DIC can result from this, but DIC does not cause this. And I know we all love DIC. We just can't get enough of DIC. I still can't explain it. Please don't ask. We just know they clot too much and they bleed too much. They are just not doing the things we want them to do. So you're going to see bleeding from places you don't want to see it. You're going to see bruises all over her. You're going to see coag disorders, as we just said. Questions? I know this is a lot. But think it's really important to know what is going on, why it's happening, catch it early with your patients, and then, a lot of these things, you know what to do, right? You know what to do with a patient who dips knee up. You know what to do with some of these things.